So I'm Dr. Cleve Bethel. I'm with the Southwest College of Naturopathic Medicine Pain Relief Center. I'm a medical doctor. I went to school at Creighton University in Omaha. Then I did a surgical internship in San Francisco at St. Mary's Hospital. I then went into anesthesia. I did my residency at University of Arizona Phoenix campus. And when I graduated from that, I started practice in Mesa, Arizona. I had the opportunity during that training to work with some of the pioneers in pain management. Richard Derby, who was an anesthesiologist when I was a surgery intern. And he was doing some weird stuff, and I decided I wanted to do weird stuff too. So when I started practice in Mesa, Arizona, I worked with another pioneer in the pain industry, Tom Grady, who had done some very interesting things. Back in the 80s when I started, pain management was not well defined. We didn't have a lot of the medications that we have now. We didn't have the techniques defined. We didn't even know some very basic things that are obvious today, like where the medial branch ran to the facet joint. So we were open to trying all kinds of things, and one of the things I tried early on was some products from Heal, which is a line of homotoxicologic products. Traumeel and Zeel are the ones we'll talk about today. Traumeel is primarily, in my mind, for acute injury inflammation. Zeel is for more chronic rheumatoid, osteoarthritic type of problems. So there have been lots of studies over the years. Homotoxicology has been in existence for all of this century and most of last century. So the reason that I got into it was that I was doing pain management in an allopathic setting, and I had an endocrinologist who was adamant I not give steroids to any of his diabetic patients. He would just go ballistic whenever their blood sugars went up above 200, which is common when you do a steroid epidural or steroid trigger points in a diabetic patient that's not very well controlled and is not on a good diet. So I searched for something else that would be equally as efficient and efficacious and not too expensive to give these patients. And I was able to actually have insurance pay for the injections. I wasn't using them in a prolo sense at that time, just in their anti-inflammatory capability. And I found them to be almost as effective as corticosteroids. Their mechanism of action is different. Their length and their onset is different. You get an initial effect, but a lot of times you need to repeat it. But then at 7 or 8 days, according to the current studies, they surpass the other modalities. The insurance modality isn't really set up for that, so you can't see a patient every day and inject them. So you do the best you can, usually with muscle strains, ligamentous strains, conditions like that, acute injury. One injection will suffice, and then maybe a week or two later you'll repeat it. And I've had patients get very good results and be very satisfied with those results. Today, usually I separate out insurance from non-insurance. If I want to do prolotherapy is basically just a dextrose solution, which may or may not contain other things. Medi Natura's protocol for that is one-to-one, basically, and that's kind of strong. So you'd use a cc of 50D50 along with a cc of Traumeel. So the Traumeel vials are 2.2 mils, so you would use 2.2 mils of dextrose. I find a lot of people that causes a little bit too much inflammation. I like to stick below 20% in the dextrose, whatever the total solution is. The way they can accomplish that easily is just to add more local. And my own personal take on local is that I like to mix lidocaine with marcaine. I get a quicker onset, a longer lasting effect, and it also tends to balance the pH. Lidocaine is usually a pH of 5.5, marcaine is a pH of 8.4. You mix the two together in equal molar amounts, you get a pH that's somewhere around 7, and it has not been studied that I'm aware of, but I'm optimistic that that reduces some of the chondrotoxicity that we see with local anesthetics. So much like much like prolotherapy, I use Traumeel and Zeel for PRP, which you'll see later today in this video. I use Traumeel most commonly with stem cells, and also with the amniotic products. And it doesn't matter whether I'm using bone marrow, which tends to be more inflammatory and they have more pain afterwards, or whether I'm using adipose-derived stem cells, which has less postoperative pain related to the injection, but more related to the liposuction. So I use pretty much the same formula when I'm doing the stem cell treatments as well as the PRP. I'll use 1 cc of my PRP or stem cell product, and then I'll use a cc of my Traumeel Zeel combination with local anesthetic, and sometimes B12 and folic acid. If I'm doing epidural treatments, I usually leave out the folic acid and the B12. So to recap, there's a variety of bone marrow stem cell preparations. Perhaps the easiest one is to just get 20 or 30 cc's of bone marrow from the iliac crest. Of that, about 20 of it's probably just blood. You then spin it down, much as you would PRP. You can use a kit that filters out any bone spicules and certainly the white cells and the red cells, knowing that you're going to lose some of the stem cells when you do that, but also knowing you'll have less inflammation overall. So not directly into that preparation, whether it's adipose or bone marrow, but afterwards. In other words, I flush the syringe with the Traumeel Zeel local anesthetic solution.
The last time this happened and flared up, I was actually moving, and I had a box above me that fell, and then it fell onto my shoulder.
Okay.
And so then that time I used some homeopathic arnica to be able to deal with the...
What was the original injury?
Original injury, I was tackled while we were actually playing flag football, so we had no gear, and it was just a perfect tackle right at the waist, lifted me up, and we landed on my shoulder, and it popped out completely. Collarbone was sitting on top of my shoulder, and I had no use of my arm.
You said you had an external component at one point?
Yeah, this is still anterior and a little bit superior compared to the other one. And it's both palpable and visible if you mark the points. And so
Okay. Was it tender when they pushed on
only a little.
it?
Yeah.
Not like the...
But every once in a while, I will feel pressure build up on it, and I'll feel it do a release. And then afterwards, I usually
Can you release it by pulling back your shoulder?
Not usually.
It's too tight.
Mm-hmm.
Okay. All right. So have you ever tried Traumeel for it before?
I have not.
Or Zeel?
This will be the first time.
Okay. So today we're going to inject your coracoid ligaments, the ones that go to the acromion and the
Okay.
ones that go to the clavicle. we looked at your films. Your MRI unfortunately didn't take the right slices, so we couldn't see exactly what we wanted, but your motion films, where we loaded the arm and pulled the joint apart, showed clearly that you had movement, a separation of the joint under load. So we know that your AC joint is separated.
Okay.
Because it is chronic and you just have acute flares, there's probably been a lot of repair, a lot of scarring in it. So our options are to use prolotherapy.
Mm-hmm.
We could use PRP, or we could use some bone marrow stem cells, or we could use some amniotic product. I was thinking the most cost-effective method for you, given that it's probably ligamentous separation, would be PRP, which in my mind I think of when I need regenerative capacity and glue.
Okay.
So
Tighten things back up.
tighten things up, put them together. So if it's a complete separation, which yours isn't, gluing two ends that aren't together probably is not going to accomplish anything. In that event, you probably want to speak to a surgeon about bringing it together.
Okay.
And they have a variety of ways of doing that. But in your case, I think PRP is a good option. And then we'll use the Zeel and the Traumeel to help control any inflammation that goes along with it. Because it's a chronic problem, we use Zeel, but because the addition of PRP, which can be inflammatory, we don't want that inflammation to get out of control, so we put the Traumeel in there to deal with the acute component and the Zeel to deal with the chronic component.
Okay. And what about anti-inflammatories for
You
me in
should
taking them?
avoid them.
Okay.
I don't have a big problem with the fish oil
Mm-hmm.
or the turmeric or boswellia for that matter, but I think you should avoid non-steroidals like ibuprofen, naproxen. And if you can have much discomfort in the next 2 or 3 days, I would use the Traumeel cream.
Okay. The topical.
The topical.
Okay.
Or the gel.
I've seen those around.
So any questions, or should we proceed?
No, I've done a little bit of research on them. I think PRP would do good, and you've answered my questions about any other supplementation stuff, so sounds good. Yeah.
Tubes always take a while to fill up.
They do.
How are you feeling?
Good.
You can make those finishes.
I do. See, it gets a little bit extra by doing the tube.
Yeah. Get a measurement of how much volume this side holds.
Mm-hmm.
Centrifuge, we're going to spin it for about 10 minutes. So, blood goes in one chamber, balance tube goes in another chamber, lock it down, and run it at 2950 RPMs for 10 minutes. And there we go. Plasma in the top layer is what we call platelet poor plasma because it's sorted by density. So the bottom of that yellow fluid layer is going to have most of the platelets in it.
Oh wow.
So we take the top part off, we can save that. There's applications for that in like aesthetics and different things. If you wanted to have a PRP facial, for example, they could have done that with that stuff. So what's left in there now is some plasma, and then there's a layer of platelets. So what I'm going to do is gently agitate the tube a few times to resuspend the platelets. Use this hub to transfer that plasma out. Usually you can tell a little bit difference in color. The platelet-rich plasma is a little bit more opaque, a little bit darker than the platelet poor. But that's what we're going to use to treat the shoulder. We got about a little over 6 cc's of that, and we'll be adding the Traumeel and Zeel to that.
Awesome.
we're getting ready to drop our Traumeel and Zeel. This is a chronic and acute recurring problem with them, shoulder separation, as we discussed previously. I always use a filter needle to eliminate the possibility of any glass fragments for the vial. So we'll take a total of 4 cc's, 2 of Traumeel. It comes in a vial of 2.2 cc's, as does the Zeel. So, whether we're transferring stem cells from a relatively non-sterile area to a sterile area, we use a little Morlock transfer. Very handy. It just allows us to plug right in. This is PRP, which we've obtained from the patient. How many cc's of blood did we draw?
About 22.
About 22. And then we just use a standardized kit to separate out the plasma, the platelet-rich plasma. And we have a total of 6 cc's of PRP. And if I could have a little local anesthesia. Just give me the local. So if we were doing Prolo rather than PRP, we would use pretty much equal amounts of dextrose to Traumeel, a 1-to-1 ratio. And then the homeopath that taught me years ago how to do this, he also suggested I always use folic acid and B12. That is not Medinatura's take on it, but they're relatively benign. I use unpreserved compounds. They felt it activated. Sometimes you want to succuss it. It's just a way of mixing it. As Traumeel and Zeel are primarily nanomolecular, it helps spread the energy around. If you just succuss it a little bit, 10 tabs is probably sufficient. And then I just use a little bit of equal amounts of Marcaine, 0.75%, and lidocaine, 1%. I feel it helps balance the pH, it stings less, and also, I hope, is less chondrotoxic. So we'll go ahead, as we discussed earlier, we have a, can I have a clear drink?
Yes.
We have an AC, chronic AC separation. From the imaging, in the exam, I believe it's a grade 2. He also has a subscapularis inflammation at the insertion on the humerus. Sorry if that tickles. And some supraspinatus tendonitis just below the acromion. It's common when you have an AC separation for the bones to reposition slightly, just enough to narrow the canal. So, a word about marking the site after your exam before you go in the room to do, are we still recording?
Oh yeah, it's over.
Okay. Is that you should always do it. I didn't do it in this case, and I ended up draping the wrong shoulder because I was busy talking and not thinking about it. So
Even in your office, it's a good idea to mark. So, this is a fluoroscope, a GD9900. And there you see I'll use the needle as a pointer, you see the acromion there. You see the distal end of the clavicular, or clavicle. And over here, the coracoid process. Can you go towards it just a little bit so we can get that more in the field? And that's the coracoid process. As you know, the coracoclavicular ligaments come off here and go up to the clavicle there. And let's see if I can do a better job. There. And then the acromioclavicular comes from the acromion to the coracoid right about there. And then of course you have the local ligaments, the AC ligaments, right at the AC joint. You can see that his clavicle is rotated up. What you can't see from this projection is that it's also rotated posterior. And to me that suggests a grade 2 separation. It also moves under load. We could probably demonstrate that. Okay, so if you'll just pull down on his arm. Wait. Okay, now. See, it doesn't move too much. This is a chronic injury. So I'm going to start with the AC joint injection. We just use a little nose sting here, which is a very dilute lidocaine. It's buffered. And that, of course, gives you your local without a lot of stinging, burning. And you can feel the ligament as you go through it. I realize a lot of you physicians doing this won't have the advantage of a fluoroscope in contrast to guide your injections. Fortunately, you can palpate just about all of these structures. I'm going to introduce a little bit of the PRP, about 3/4 of a cc. And you can see it spreads the contrast. You okay?
Mm-hmm.
Is it causing much discomfort?
A little bit. Not too much though.
So I can tell by the difficulty injecting that he has a bunch of scarring going on there. Now I'm going to go ahead and put in the Traumeel and Zeel just to flush the syringe or the needle, and to give him a little local for now, because we don't actually see the ligaments, I'm going to use my sense of touch just as you would do if you're doing this without fluoroscopic guidance. And just when I feel the needle hit the ligament, then I stop. An easy way to do that is go ahead and hit the acromion process with the end of the needle. There we go. And you can see it start to spread down the ligament. And because everything we're injecting is a fluid, it'll spread along the ligament. I'm going to do about a cc of the PRP in each area.
the same amount of the Traumeel and Zeel solution. Other than in a really big patient, you can probably do this with about 1.5 inch long needle. Did you feel kind of a deep ache there
Yeah.
with that? Okay. Yeah, they can tell you when you're there, they'll feel a deep ache. And they'll go ahead and inject there. And of course, if you're doing this without image guidance, you want to take the needle out and reposition it more medially. Because I am using a fluoroscope, I can palpate the clavicle and just move my needle over to the right spot. At the attachment of the other acromioclavicular ligament, you see it spread down along the ligament there. Did you get as deep an ache on that one?
Not as deep, but it's still there.
Still there?
Yeah.
It's with a grade 2, it's usually the lateral acromioclavicular ligament that is strained or partially torn. Okay.
Yeah. Just full pinch.
I'm just going to run over and get the enthesis on the coracoid. That's good.
That's aching.
That one aches?
That's aching.
Good. Now I'm going to get their attachments of the supraspinatus and the subscapularis to the humerus. Can you wiggle this around to kind of show me the bicipital groove in the humerus? So that's good. So right here is where the lower portion of the bicipital groove is. And as you know, the subscapularis attaches on both sides of that groove. So we'll come in right over it, little pinch. You get that deep ache?
Yeah. Especially there.
Yep. We want to go toward the superior edge of that enthesis, because most likely your patient is going to be upright. is part of the time after you inject. So you want the stuff to be able to run down a little bit, cover the rest of it. Then I'm just going to move over to the, and you can palpate the groove right there. You don't have to have imaging for this. And that's perhaps a little medial. Right there?
Yep.
Yep. And once again, your patient will tell you when you're there by that deep aching feeling.
Definitely achy.
Little twitch there. Okay. And is this tender down in here? The attachment of the supraspinatus can go a variable distance down the humerus. We'll just come down below the ball to catch it. Another good ache?
Yeah.
Okay, well, this will be our last spot, and then you're done. All right, thank you. If you have any questions, and I'm sure you will, we'll be happy to answer them. So I know that I've left a lot of questions in your mind, at least I hope I did, because I'd like to hear from you. And I guess as part of this webinar, you're going to be able to phone in questions, or this will be presented in different formats. So I'm always happy to help you get started in your injection practice. I think using Traumeel and Zeel are very safe. The risk-benefit ratio is just incredible. There's almost no risk other than with the needle. But the medication, there's almost no risk. I've never had an adverse event with Traumeel or Zeel, and I've been using it for probably 25 years. If not a little longer. I've had good results, satisfied it doesn't produce the same results as Canalog or Depomedrol. It works very differently, but particularly for acute problems, it's very good to control that acute inflammation, swelling, bruising, very useful for that. I have many patients on the topical Traumeel, and that's very effective from them. It's equally effective with diclofenac gel and other topical preparations that are primarily camphor or menthol. In fact, it's usually much better than camphor or menthol, which is primarily a distraction from the pain rather than treating any of the inflammation. What else can I tell you? So, to recap, very low risk, very good benefit. So, feel free to experiment and get started with it. So, I know there's a lot more things we could talk about today, but I don't want to waste your time. I'd much rather have you ask me specific questions that I could answer, and we'll talk about it then. So I look forward to your questions. I hope this has been worth your time. Thank you.